It's great to be back this year. Last year I was hostessing the mobile health track in a separate room, and it's fun this year to have everybody together. In focusing on mobile health last year, I felt excited to be there. It was a great year for mobile health, but I also felt like we were missing 95% of other things. And today I want to focus on connected health. So I want my fellow panelists to come on up and grab a chair over there. We're really lucky to have these three people with me, Dr. Joseph Kim, Sandra Elliott, and Brett Shamosh, and they're each going to present part of this presentation to you today, and then I'm going to tie it all together at the end. So let's see if this works. Okay, this is our title, 360 Degrees of Connected Health. Last year, I wrote a report for California Healthcare Foundations called How Smartphones Are Changing Healthcare for Consumers and Providers, and just focused on mHealth, where I met Joe Kim and Brett Shamosh as my interview subjects, amongst others. You know, that was good so far as it went, but again, as a health economist, I feel like I was missing a lot of the picture. And for the first time at this conference in the last 2 days, we're going to talk about whole health, the whole continuum of health, from birth, health, wellness, all the way through to illness. And this is how I look at health as an economist, the way the World Health Organization looks at health, which is not just the lack of illness, but the whole state of whole mental and physical well-being. And this morning, there was a fellow conference going on at AHRQ, where ePatient Dave went last night and is there today and has been tweeting. But if you follow their tweets today, you'll find they have a whole track just talking about mental and spiritual health. So we're actually going to mention that in here as well. This is an old drawing from my public health days in 1993 by a Canadian public health person, Trevor Hancock, which really talks to all the touch points in our lives that bolster health. This is one of my newer heroes, Dr. Regina Benjamin. You should get to know her. She's your Surgeon General, your tax dollars at work. And what she told an LA Times interview earlier this year, which has become a mantra for me in a lot of my writings, a lot of you who read my blog every day or even weekly will know that lately I've been saying, per Regina, health is where we live, work, play, and pray. You can't look at health in isolation, she says. And that's what this panel is about today. It's tying some things together because we all live 24/7 lives, and very little of that time is spent with a doctor. The other meeting I should have been at Monday and Tuesday, but I was here because I love social health, and Kevin and Christine, is the UN NCD meeting in New York. And NCDs are non-communicable diseases. These are not the communicable diseases that people used to die from. People used to die from infectious disease, most people on the planet. Today, most people on the planet in developed countries like ours, Europe, the developed parts of Asia, and developing countries, the poor countries, we're all dying from things that we can largely prevent through changing 4 aspects of our lives: smoking, alcohol intake, eating right, and getting off of our duffs. Mayor Bloomberg in New York yesterday told the UN group that he believes the #1 issue that permeates the top 4 chronic conditions, heart, cancer, respiratory, and diabetes, is smoking. That is Mayor Bloomberg's view. In any case, move the needle a little bit, like Talia was talking about earlier on adherence. Move the needle a little bit on all 4 of these things. You save a lot of money in the health system. And in this country alone, we spend now about $2.5 trillion on health, about 80% of which goes to those NCDs, chronic conditions. So again, when we talk about bending the cost curve, you know, let's get to chronic conditions. The paradigm I want you to keep in mind is, Kevin and Christine said, you're going to have 3 people on your panel. How are you going to do that in a half an hour? And I said, well, I'd like to have 6 people because I also want somebody from food systems and somebody from technology, broadly speaking, and someone from, say, a health insurance plan. But in each of our lives, we each have this personal health ecosystem. And pharma in the room, you are this part of that, very small. People engage in other aspects of health and healthcare in a lot other ways. So this is more information than you want to know about me, but I want to play this out for you and have you think about in your lives, what is your personal health ecosystem? So mine has to do a lot with food. I'm a member of the slow food movement on the upper left, and I cook, and I'm blessed to live around here where I have choice of 3 Wegmans to shop at. Shout out for Wegmans. I know I love it. I get my annual mammogram. Art and music are important in my life. My husband, my daughter, my spiritual life, very ecumenical. My withing scale and my Fitbit, and click, I didn't get one from you. I bought it myself. And movies are important to me as well. So these are some of the things in my health ecosystem, the arts community as well, the Mayo Clinic meditation app. Anyway, think about these touch points, because when now we talk to our patient/technology person, Brett, he's going to speak to a lot of these elements in his own health, whole health. So Brett, why don't you come up here, and we're just going to go from speaker to speaker and ecosystem point to ecosystem point.
Sure, thanks, Jane. Hi everyone, I'm Brett Shamosh, and I'm going to share my journey with you today on everything I've learned along the way. 3 months ago, I lost my colon. So if you see a colon lying around, turn it into the lost and found, because it might be mine. I kid, I had my colon removed intentionally by a trained professional. And this was the culmination of a 20-year battle I had with ulcerative colitis, during which I was a pretty terrible partner to my physician. And the reason I was a terrible partner is because I fell victim to what I call the patient assumption, right? We all think we're going to go into the doctor's office, he or she's going to ask us some questions, maybe do an exam, order some tests, figure out what's going on, given their medical background, and sort of send us on our way. And you may or may not be familiar with a SOAP note. So SOAP note is fairly standard medical practice. At the end of a physician's visit, they'll put this together. It's an acronym that stands for subjective data. This is the data that the patient gives the doctor about how they're feeling and their symptoms. There's objective data in the form of a physical examination, blood tests, x-rays. There's the assessment that's put together as the result of collecting all this information, and then a plan is put together based on this assessment. Now, the major flaw in this patient assumption is that we underestimate the power of this subjective patient data as it relates to the assessment and the plan. In fact, in 1/3 of chronic illnesses, I'll repeat that, 1/3 of chronic illnesses, there's no clear biomarker for treatment. So what that means is that your treatment, and sometimes the diagnosis, is almost entirely dependent upon that conversation between the doctor and the patient. And all too often, that conversation goes a little something like this.
Hello, Dr. Williams.
Hello, David. How have you been feeling lately?
I have been having some pain.
Okay, where have you been having pain?
The pain has been on my body.
Where on your body?
Yes,
On which part of your body do you feel the pain?
the main part.
Okay, how would you describe the pain?
It hurts.
Is it a sharp pain or throbbing pain?
I think so.
When do you get the pain?
Usually when it hurts.
Does it hurt at night? Does it hurt when you wake up? Does it hurt after you exercise?
Yes, it does.
Can you rate your pain on a scale of 1 to 10?
Yes, I should be able to do that.
Can you tell me a number for your pain on a scale of 1 to 10?
Yes, half of the time it is an 8, and half of the time it is a 2.
Okay, when is your pain an 8?
When it hurts really bad.
And when is your pain a 2?
When it doesn't hurt so bad. Am I using your scale correctly?
Yes. I am trying to figure out when your pain is the worst.
My pain is the worst when it hurts really bad.
When you get the bad pain, how long does it last?
Usually until it goes away.
Okay, are you experiencing any other symptoms?
Probably.
Which other symptoms are you experiencing?
I don't remember.
Have you had any nausea, dizziness, shortness of breath?
Haven't we all?
Yes, we have. In fact, I think I'm having some of these symptoms right now.
You should really see a doctor.
So obviously a bit of hyperbole there for the entertainment factor, but I would submit to you that I was just about that helpful to my doctor in the 18 of my 20 years with ulcerative colitis. So here I am in 2009, and I get another bad flare-up of my condition, and I have this epiphany, like, hey, I should probably be a little bit better about giving my doctor accurate subjective information. So it's 2009, I did what anybody did in 2009 when they had an idea. I built an iPhone app. The iPhone app was called GI Monitor. It allowed me to record my symptoms and print out an accurate report for my doctor since the last time I saw him. Today, fast forward a couple of years, GI Monitor is available across Android, iPhone, online on the web, syncs in real time. It also has a social component. So while people are actually recording their symptoms and realizing what's going on with their body, they can discuss these things. Furthermore, they can print out a nice, simple, accurate report of the subjective data, and most importantly, in the way that the doctor is going to ask them about their symptoms anyway. So your pain on a scale of 1 to 10, for example. And then lastly, the patient can dive into their own symptoms and draw correlations between event A and event B. For example, what did I eat? And then how might that have affected my pain or other symptoms? We even connect with Foursquare, so users can plot their check-ins and realize I went to this restaurant and I felt this way the next day. And the hope is that David ends up at his next appointment something more like this.
David, it is good to see you again. How has your pain been?
Hi, Dr. Williams. Since I last saw you, my pain has averaged a 7 out of 10. The pain is in my lower back on the left side, and it seems to be the worst when I wake up in the morning. I have been tracking the pain with my iPhone, and I can provide a detailed report showing when I get the pain, how bad it is on a scale of 1 to 10, and what I was doing before the pain started.
So my personal belief is that the collection of accurate, subjective patient data can change the course of human health and wellness in so many ways, all the ones I have listed here, not the least of which is research, because it may lead to areas of discovery we haven't even thought to look into yet. When I was post-op after my colon removal a few months ago, I had some pain, and I just sort of knew that it wasn't normal post-op pain, and I had this discussion with my surgeon. My surgeon said something to me that stuck. He said to me, the dumbest body is smarter than the smartest patient. I'm sorry, that's not what he said. He said the dumbest body is smarter than the smartest doctor. And I thought that was a profound statement, and it's something that stuck with me, and I believe it, and I write about it a lot. So if you'd like to follow me, I'm at WellApps, and I hope you will all know yourself well. Thanks for your time.
All right, well, my name is Joseph Kim, and I am going to be sharing with you some perspectives from a healthcare professional standpoint. I am a non-practicing physician, president of a medical education company called Medical Communications Media, also very active in social media, blogging, engaging folks on Twitter, both on the healthcare professional side as well as on the patient and consumer side. And I want to sort of take a journey back to 1993, where at that time, one of the most advanced technologies was this device called the Apple Newton. And unfortunately, Apple killed the Newton in 1998. A lot of the engineers then went over, created Palm Pilot, and we know where that ended. But the Apple Newton was actually very popular among a small group of healthcare professionals who really wanted to get engaged and record data on a mobile device. At the time, there were apps. They were all black and white. You could chart patient data. You could look up drug information. And it was really, really advanced for its time. It also had powerful clinical decision support built in, and people were actually researching using these devices and publishing papers, presenting at meetings, and doing things where most of the audience weren't really paying attention because these were early adopters, it wasn't mainstream, and one of the biggest problems was that the device was so expensive. I mentioned Palm Pilot, and I think most of us in this room probably had one at some point using it as a PDA. And the same thing was happening in the hospitals. Doctors carried these things around. Medical students would use them to look up drug dosing. And Hippocrates came around in 1998 to offer free medical information, drug database information for physicians and students. And just, you saw Palm Pilots everywhere you went. And when we compare where we've come from 1998 to today, most of us in this room have a smartphone, whether it's a BlackBerry, an iPhone, an Android, or whatever it might be. And most of us have a device that has a color screen, multimedia rich. So just the comparison in this time period of that grayscale screen, of purely that sort of informational reference to what we have today, rich multimedia, pill photos, as well as the ability to communicate wirelessly. It's taken us leaps and bounds over a very short amount of time. And what I want to highlight is what's happening in this whole world of digital health. Earlier we saw, the robot that was coming around, and even if you don't have a robot, but you have a webcam or a phone with a camera on it, you can actually engage in telemedicine. So you no longer need to be in a sophisticated tertiary care medical center that has the latest and greatest in terms of telecommunications, but rather you can just simply engage with your healthcare professional by taking a photo of a patient. In this lower example, we see someone, there's a child in the background. Doc, my child has a rash. Well, is the rash red? Is it raised? Where is it? Is it blotchy? What happens if you press on it? You can now transmit all of this information using real-time communications, and it's available to most consumers, most patients. We're also seeing some major advances in these other areas like dermatology, radiology, and cardiology. And we saw some of these examples earlier, so I'm not really going to spend a lot of time. Airstrip collaborating with other groups out there, allowing EMT, emergency medical technicians to actually wirelessly transmit data to the hospital while they're en route, and getting instructions from the hospital to say, this is what we want you to do with the patient right before you get here. HandyScope is something that's currently available in other countries where you can actually take photos of a rash, it attaches to an iPhone, and you can zoom in, you can get polarized light, but the most powerful part about this is you can transmit that data wirelessly now to another healthcare professional who can diagnose what that rash is and give instructions. So if you think about it, the person holding that HandyScope doesn't even have to be a healthcare professional. It can be a local, everyday layperson who simply just knows where to put it, what buttons to push, what buttons to transmit the data. Then the healthcare professional on sort of the other side, if you will, instructs that patient on what to do. We're also seeing innovations leveraging the capabilities that are built into the phone, like the GPS as well as the accelerometer. And this is an example of an app that physicians around the country are using, oncologists predominantly, where if they have a patient and they're in a rural area, patient has a malignancy, and they ask, Doc, where can I find the nearest clinical trial? Instead of opening up a computer and going to clinicaltrials.gov and just kind of going through that whole process, you can simply just click some buttons. It knows where you are based on a GPS on your phone, and it gives you a list of some clinical trials within that geographic area. So a very powerful tool. Things like this eye triage, once again, uses the built-in GPS to then turn into a navigator. So even if you don't have a GPS in your car, if you want to know where's the nearest ER or the nearest urgent care center, it'll actually give you walk-by-walk or turn-by-turn directions, depending on whether you're walking or taking the car. In addition to this, we're now seeing ERs broadcasting wait times, and iTriage is one of those apps that actually leverages and taps into that database. So if you want to know what those wait times are in your local area, you can actually get a list of that, and then that may help guide people. And when you think about, from a healthcare marketing standpoint, what hospitals are doing and what they need to keep up with today, these are the kinds of technologies that are out there. We're seeing Walgreens and other pharmacies making it easier for patients to refill their prescriptions. This is an example of an app where you can scan the barcode on your bottle, and then you can transmit that refill right to the nearest Walgreens. There are other apps out there where you can actually scan the barcode on over-the-counter products, and it picks up that this is Tylenol cold. Then you can list what other drugs you're taking. It may warn you of potential adverse reactions and things like that. So a lot of consumer-based, consumer-centric apps really on that pharmacy level to improve the access to medications, but also to make it easier for patients to get their prescriptions filled, or to make sure that they're avoiding adverse reactions. This one also has the ability to inform patients about the nearest flu shots at Walgreens. Within the healthcare space, and in really the space where I work day in and day out, is within the mobile education space. Physicians, nurses, pharmacists, NPs, PAs, they all need continuing education. More and more of that is now being delivered via mobile devices and mobile platforms. We're seeing a lot of it on Hippocrates, which is powered by Real CME. ReachMD, which is a satellite radio station. They also have an app. Quantia MD, which is a mobile community. MedPage Today, Medscape. And there are a number of other communities and apps out there that are providing healthcare professionals education at the point of care, but also making it short, making it relevant, making it very concise and applicable. And this is just a very, very brief snapshot of some of those mobile communities that have emerged. Surma has been around probably the longest. Doximity is one of the newest. But we're also seeing some that are specialty-centric, like MedTrust for oncologists or OrthoMind for orthopedics. And this is an area that's rapidly going to evolve, and I think we all need to know how to tap into these networks appropriately to make sure that physicians are communicating appropriately with one another, but also helping each other in terms of managing patients and making sure that this is not just a place where you're just complaining about politics or talking about religion or just, where people are just sharing and venting, but rather making sure that these are constructive conversations that are ultimately improving patient outcomes. So with that, I want to thank you for your time, and I look forward to the interactive dialogue we're going to have, and I'm going to pass it on now to Sandra.
Thank you.
going to try and go through this as quickly as possible because I want to make sure that we have plenty of time for questions. My name is Sandra Elliott, and I'm here to actually represent a healthcare provider, a health system based in New Jersey. And real briefly, not-for-profit health system, working with close to a couple of thousand physicians in the local community, 6 hospitals, a number of health capabilities within the continuum. Virtually every element of the continuum you can imagine, with the exception of a funeral home. The board will not go for it, you know. So we haven't done that, as well as we just sold off some assisted livings because the market was changing very dramatically. What's important to understand about the continuum and the elements of the continuum is, as we looked at where things were going in the future, we really wanted to understand where are the weaknesses, what services or capabilities do we need to take into consideration to build to meet the future needs of our patient populations. And as a result of that, we began to realize and focus less on bricks and mortar and having people come to us and looking at how we can come to people where they are, where they live, play, and pray, and work, and all those kinds of things. That's it. So as a result of that, my role was to look in technology and understand, particularly as it related to living independently and aging population. We have a very large aging population. And as a result, we decided to bring in a number of different technologies. I've piloted every blessed technology that's out there, from a telemonitoring to home monitoring, whatever you call it, we've tested it. And as a result of that, we realized that there were kind of some core messages that we needed to kind of take to people, potential vendors, when they were looking at trying to pilot technologies with us. 1, it has to be extremely low cost. 2, it has to be easy to engage in the consumer's life, in their day-to-day life, and it can't look medical. And as a result of that, what happened is we actually spent a lot of time focusing in on listening to the patients. So one of the things as a health system that's very difficult to give up is thinking that we prescribe, we know what's best for our patients. We know what's best for our patients. We give them prescriptions all the time. If they would just do what we tell them, then all would be fine, right? But the reality is that patients' needs and patients' lives are very different than the prescriptions that we give them. So how do we integrate into that? So we said, okay, you know what? We've got to spend some time in the hearts and the minds of the consumers, where they are, in their homes. If I am a family member taking care of another family member, I've got to spend time and understand what their struggles are. So we went through a very specific ethnographic process to look at what's important to consumers, what are truly their needs, what is it that they currently do on a day-to-day basis, and what technologies can enable us to help them meet their needs. Not necessarily meet our needs as a health system, but meet their needs. We looked at bringing in expert interviews, the physicians, the pharmacists, et cetera, and a number of groups sessions as well. And the result came in, it wasn't about demographics or products or services and needs by demographics. It was needs by where people were within their own health, if you will. So from cruise control people who have had a chronic condition, who are really just trying to figure out the easiest and most efficient way to stay on their regimen, to the boot campers, or I call them the oh crap, holy crap moments, where all of a sudden you've just been diagnosed with a condition and you need to learn more about that condition and how do I have to change my lifestyle, if you will, to I've just got high blood pressure, I take a pill, it's no big deal kind of thing. They're all very different patients, very different patient needs, and the solutions that can fit into those environments for those individuals are very, very different, if you will. As a result, we actually spent a lot of time looking for technology to help us meet those needs, and as a result of, particularly on the low-cost side, not being able to kind of come together with some of those, we decided to kind of start developing our own. Not to think that we could actually build and solve world hunger, if you will, but begin to understand a little bit more about the process. So we actually came up, and we have a joint venture with a technology-based company out of Sweden, where we're developing kind of like a deck of cards to monitor your health, if you will. So literally, credit card size form factor. Why would we want this? Portability, it's easy, doesn't look medical. Oh, by the way, I will tell you that there are a lot of older patients who will say, don't just put Paisley on the outside of those crappy pieces of equipment that you have in the hospital and think I'm going to use it, because it still makes me feel sick. So, and that's what we've done over time. You've got to look at the form factors and making sure that people actually find that there's value in the product and it doesn't make them feel sick and it's portable, if you will. So we've defined both sensor-based cards, and as you saw in one of the previous presentations, electronic health journals. where people can actually begin to document some of their, in a very portable way, document some of their symptoms, and easily update that information through mobile technology, if you will. So for example, this card is a sleep track card. So it monitors your sleep patterns every night. Then I literally am going to leverage what's called NFC technology, which is touch and post. I literally will touch it to my mobile phone. It uploads that information, puts it graphically however I need it to go, to look, and then sends it wherever it needs to go. But the consumers absolutely felt that this enabled them to kind of mix and match based on the different technologies to meet their specific needs. So we were trying to customize things for them. As I mentioned before, you literally can take these cards because of the way the NFC works. And NFC is fairly new technology in some of the mobile phones that are coming out, but literally touch. All the information that you've collected, date and time stamped, is actually uploaded to the mobile phone, and it's very secure, and like I said, it can go anywhere you want it to go. So what we were trying to do, I'm going to go back to the low-cost option, because when we were testing out different types of technologies, connectivity was a major issue too. So why not leverage mobile phones, because they're out there. Mobile phone service is much better than it used to be. Why can't I leverage an existing person's mobile phone? And that's actually why we wanted to leverage NFC, because a lot of the mobile phones are becoming much more smartphone-oriented, NFC-oriented as well, which if anybody heard about Google Wallet and some of the phone-based banking capabilities, that is actually beginning to embed NFC. So as people actually have those phones, why not leverage that capability? So I can keep this at $25 or $30 a pop. And that consumers can understand that there's a different value. I call this we actually call this the the copay strategy, the copay pricing strategy. If you can get anything priced, service, product, et cetera, and we've learned this from the consumers, at a price point that is comparable to a copay, it's a lot different kind of sell for a consumer, primarily because they're comfortable paying for that already. So if you've got a direct-to-consumer model and you've got something priced extremely high, you better be demonstrating a heck of a lot of value, because they're not going to buy it, because they can get a doctor's office visit for $30. Anyway, there are a lot of new technologies coming out that'll leverage the phone. These are the core areas that we're developing different technologies for. Again, the ability to mix and match some of these capabilities enable us to create solutions specific to certain patient needs. When we put these technologies in front of consumers, they came up with the different business models and different distribution channels for us. We didn't have to do that. So for example, if I have a cholesterol test, again, a card that I can buy very quickly, maybe I want to lose weight because my doctor just told me my cholesterol was high, and maybe I can stay off of a medication if I can begin to lose weight. So literally, we had people who were saying, if I can do a cholesterol test, maybe use a food journal to document my food intake and start using a pedometer like that as well, then I can actually begin to see whether or not my diet and exercise routine is having an effect on my cholesterol by simply doing another cholesterol test. So, and you see the EPT, and we actually had people starting to say, oh, and you could do itemized shopping lists for food, et cetera. So they actually were very, very helpful in helping us, once we started listening, understand how we could actually put some of these devices together, package them very differently to meet their needs, and help them take more ownership. One of the things that we're doing at Meridian Health is actually leveraging some of these technologies based on our readmission, high readmission rates in certain areas, so we can actually put a kit together, give to the patient, because economically it's very, very inexpensive when you start looking at this technology as compared to some of the other technologies, so that patients can begin to learn how to monitor themselves in a very different way, specifically to hopefully identify some of the issues much sooner before they're actually ending up in the emergency room, and get that information to their primary care physician so that we can intervene earlier. I think that, very quickly, just to summarize, I think the key focus is it's got to be innovative. It cannot be the same old, same old. You've got to get out there and really identify something that's very different, so that consumers will say, I get this. This is really cool. Because cool factor is cool, and sex still sells. So it's okay to use those. Make sure it's very interoperable, that the devices and the technologies and some of the platforms that you're talking about have the ability to integrate information and data devices from different aspects, as well as making sure that it's easy to fit in a day-to-day life of a consumer. I will tell you that one of the things, and I'm a little over time, but I think it's important, I want to redefine the KISS principle. Everybody knows the traditional KISS principle, keep it simple, stupid. It's not about keeping simple stupid. I think when you're beginning to understand how to develop products and solution sets to get consumers engaged, you got to find out what they will use, and you got to start out small and simple. So it's really about keeping it simple and starting small and growing from there. And I think you'll find that you'll learn a lot when you actually are able to start small and begin to grow from there. But that's it. Sorry.
So I'm going to put some more context around this and integrate it a little bit. Yesterday, we saw the wonderful Meredith Resi from Manhattan Research show a drawing not dissimilar to this about digitally maturing and participatory health, which is a phrase I use a lot these days, and I'm happy to see she's using it as well. So let's talk about an N of 1, a patient newly diagnosed with a heart issue, and he or she at the lower XY quadrant gets diagnosed, and in terms of health engagement, the first sort of level is, I'm diagnosed, as you were talking about, the holy crap moment, I guess, in this case with a blood pressure issue or cholesterol. Doctor prescribes a statin. So you're driven to do research, you go to Consumer Reports Best Buy drugs, maybe you take fish oil pills, and as you both digitally mature up this curve in terms of your use of the internet and then social networks, because Susanna Fox tells us the more digitally mature we get, the more we engage in social networking over time, and that could be for young people and older people. To Sandra's point, we can't just look at demographics in this. We have to look at things like digital maturity, because grandma can be digitally mature versus a young slacker who isn't online. So don't stereotype at either end. Anyway, as we mature with our conditions and with our relationship with the internet and technologies, we go through this curve of participatory health where increasing over time and maturity in all those levels, we engage more with our physicians, if we choose to, with technology, with the health system, and with these other touch points. And what's interesting, say, about the Walgreens app that Joe talked about is not only can you do all those things with your OTCs and your RXs, but they also have a part of the app where you can develop your photos. So Walgreens realizes that in our lives we are multidimensional, and there are many things we want to do on a shopping trip. And Sandra noted at the bottom of her chart the relationship the institution has with Best Buy and other places. So I think you have examples here with Brett talking about his relationship with both his technology, food choices, shopping, Where's the Toilet app. I know I have that for different reasons than you might. When I'm in Manhattan, I really need that sometimes. Anyway, I think it shows you that people live their lives 360 degrees, 24/7, and these are 3 real-life examples of people, I think really bright lights, and I can brag about you, in their respective spaces who are really doing things that are very real, connecting health to people, and supporting health consumers, health citizens on this, our own evolutionary journeys toward participatory health. Now, that's the nirvana, holy grail part of the discussion. But there are a lot of barriers for this happening. And on Monday at Social Health, I talked about some of these barriers, and I classified them in 3 ways. They are structural in terms of the health system. Does somebody have health insurance and access to a primary care provider or health care? They are physician-oriented. Will Dr. Joe's colleagues in the physician community want to participate with patients? And we heard a little bit about that yesterday from Brian and Kent, the physicians up here. And finally, there are the patient-level barriers in terms of health literacy, which we heard people talk about today, couch potatoism and lack of health engagement, lack of self-efficacy, and what Judith Hibbard calls patient activation. Here's another structural barrier. We have a bloody complicated health system. When you're newly diagnosed with a disease, and I'm sure my patient friends up here would tell you this as well, and if you have anybody or yourselves who are newly diagnosed, when you have to understand your health insurance and where to go for a second opinion, etc., this is what the health system looks like according to one artist in The Atlantic magazine a couple years ago. It's very labyrinthine and very difficult. So we have health literacy and health system literacy issues as well. Another structural issue, the last mile of broadband. There are many parts of this country who really don't have access to the kinds of technologies most of us do, and to the width of band that you need to do a lot of the things we take for granted every day, even in this room at $75 a pop. Thank you, Kevin. So this issue of the last mile, the FCC broadband report has a huge chapter on the importance of broadband in health. And finally, physicians and patients don't always want to measure the same things. A lot of us don't want to get on the scale and look at our weight versus some doctors want to see us measure our weight, blood glucose, whatever. So we all have to be on the same page to be on this participatory health journey. At the beginning of Social Health on Monday, Todd Park gave an incredible talk that he always does on data liberation, which is how do you get data liquidity in the system? Data resides in health data silos, in pharmacies, in doctor's office, hither, thither, and yon. And ultimately, we want that data to come together for the right patient at the right time so we can make good decisions, both patient-borne decisions and physicians.